My name is Philip McGuire. I'm from the Institute of Psychiatry in London, which is part of King's College London. And this is a kind of summary of what I'm going to try and cover in the next half an hour or so. So I'm going to talk a little bit about the differences between CBD, cannabidiol, and THC, and then show you some data on the effects in healthy volunteers and experimental studies of CBD on behavior and symptoms and on brain function, and then talk about the results of the first clinical trials of using CBD as a medicine in patients with schizophrenia and in people at high risk of schizophrenia, and then a little bit about future plans. So this is a picture of one of my colleagues, Amir. He's not in Marta's back garden, but he's in the top secret plantation belonging to a well-known cannabinoid pharmaceutical company. And the plant he's surrounded by is the source of these two major constituents, CBD and THC. And you can see from the molecular structure, they're actually quite similar, except in the area highlighted in yellow. But despite this molecular similarities, they have really different behavioral and pharmacological properties. So Marta has covered this in great detail. I mean, I think all I would say is that one of the first clues to the influence of CBD on cannabis comes from anecdotal reports from illicit cannabis users suggesting that the higher the CBD content and the lower the THC content, the less likely they were to have paranoia and other psychotic experiences. So the first stuff I want to show you are data from studies in healthy volunteers. So we're taking people who have zero risk, zero vulnerability to psychosis or substance use, healthy people, and exposing them to pure molecular THC or CBD or placebo. So the design of these studies is that the same individuals are being tested on 3 separate occasions with either one of the THC, CBD, or placebo, and then we're looking at the effect on psychotic symptoms. And what you find is, on average, if you give a healthy person a big enough dose of THC, they will pretty reliably experience acute transient psychotic symptoms, whereas CBD is no different from placebo. And if you do the same kind of experiment, but instead of giving the THC and CBD separately, you give them in sequence, you find something really interesting. So if you preload subjects with CBD and then give them the THC doesn't produce any psychotic effects. So this is a remarkable finding that pre-treatment with cannabidiol blocks the psychotogenic effect of THC in the same individual. So this is one of the first clues that CBD might have antipsychotic properties, because it's blocking the antipsychotic effects of THC. So in these subjects where we were doing these behavioral studies, at the same time we had them inside the scanner so that we could look at the effects of THC and CBD on their brain function. And this gives us a clue as to why THC and CBD might have such distinct behavioral effects. And we did studies in about 8 different cognitive and emotional tasks, but the core finding across all of these different conditions is that there was a consistent pattern of opposite effects on neural activation of THC and CBD. So if you take the same healthy individual and study them doing the same task, but either after CBD or after THC, the THC and CBD seem to have effects on a given brain region in opposite directions. So in the top image, the hippocampal response to a task, you can see that in this case, THC is reducing activation in the hippocampus, whereas CBD is having the opposite effect. And then you can see the same kind of pattern in another task in the striatum. So across a range of different paradigms, this opposite pattern of activation was seen. So this was more evidence for thinking that maybe CBD might be useful as a kind of antipsychotic. And the first person to really bite the bullet and start giving CBD to patients was Antonio Zuardi in Brazil. And he published in the 90s and early 2000s some case reports where he just tried giving CBD to patients with schizophrenia. And these were usually patients who hadn't responded to conventional D2 drugs, but did seem to respond with CBD. And he found the same kind of thing in patients with Parkinson's disease who had developed psychotic symptoms as part of the Parkinson's disorder. The first trial, as opposed to a case report of CBD in schizophrenia, was done by Markus Luecker in Germany. And this, you know, it's worth remembering, this is 2012, is not that long ago. So he compared CBD and amisulpride, which is a widely used antipsychotic in Europe, and he got patients who were admitted to hospital because of a relapse of schizophrenia. So these are chronic patients who've come in with an exacerbation of illness. And then he randomly allocated them to either CBD or amisulpride. And the key finding is shown in the graph here, that essentially in terms of the effect on positive psychotic symptoms, there was no difference between a regular antipsychotic and CBD. The first placebo-controlled trial of CBD in schizophrenia, we published this last year. This was a study we did with the GW formulation of CBD. It was sponsored by GW, and this was a multi-center study across 15 centers in Europe. And the design of this study was to take patients who had chronic schizophrenia, who had had appropriate antipsychotic treatment with one antipsychotic drug, but still had significant persistent symptoms. So the question was, if we added adjunctive CBD to their existing antipsychotic treatment, could that improve these residual symptoms? And this was compared with a placebo. So in this study, we gave 1 gram of CBD for 6 weeks compared to placebo. There were 88 patients, and they were very similar in terms of their clinical features and their demographics at baseline. And these are the main, we didn't control which antipsychotic they were already on. We just took whatever they were taking. And these are the main ones that they were having. And you can see that we didn't allocate people by antipsychotic, but just by chance they had similar levels or similar frequencies of the different drugs. So the first main finding was that if we looked at the PANSS positive rating over the course of the 6 weeks of treatment, the patients who were getting cannabidiol showed a significantly greater reduction in positive symptoms compared to the group on placebo. And the other main finding was that we asked the clinicians who were managing these patients who were blind to the treatment status to rate how their patients were doing at the end of treatment using the CGI scale. And what they reported was that more of the patients who were in the CBD arm were much better or significantly better compared to those in the placebo arm. So this was also a significant effect and might be more clinically meaningful than a change in a PANSS score. And one of the exciting things about CBD, apart from its possible therapeutic effects, is its tolerability. So in this and in all of our other studies, if you compare people who are being given placebo and CBD, there isn't a significant difference in the side effect profile. So the incidence of adverse events is not significantly different to placebo, and that's what we found in this study. So from that small trial, the conclusions were that adjunctive CBD looked quite promising as a treatment for schizophrenia, and it was also associated with a very low incidence of adverse effects. Okay, the next trial I want to tell you about is at an earlier stage of psychosis, which is the clinical high-risk stage. So this is the phase that precedes the onset of psychosis, usually in the early 20s, where patients have attenuated psychotic symptoms and various other features that may lead them to present to clinical services. So it's a clinical syndrome, it's not a genetic syndrome. It's a clinical syndrome that's associated with a very high risk of developing psychosis in the next 2 years. So about a quarter of people who have this syndrome will have a first episode of psychosis within 2 years. And the typical presentation is attenuated psychotic symptoms, which are qualitatively the same as you would see in schizophrenia, just quantitatively less severe. And this is usually in the context of a severe and sudden decline in function. You also get lots of comorbid depression and anxiety, and characteristically lots of distress. So the reason these individuals present to early detection services is because of the distress. They have more insight than patients with schizophrenia, and so they're very much aware that something horrible and frightening is happening, and they have a lot of anxiety because they know that they have a mental health problem. So if you don't treat people at clinical high risk, this is the kind of natural history. So there's been countless studies that have prospectively followed this group and looked at the clinical outcomes. And on average, about 25% within 2 years will become psychotic. Of the people who don't become psychotic, many will have persistent symptoms below the threshold for a first episode, and other people, their symptoms will resolve. So at the moment, there isn't a licensed treatment for the clinical high-risk group. This is a relatively new field. It only has existed for about the last 20 years, and a number of things have been evaluated, but there is no established effective licensed treatment. Ideally, if we had such a treatment, it would do two things. In the short term, from the patient's point of view, what they want you to do is get rid of the very distressing presenting symptoms, the paranoia and anxiety. They're not particularly bothered about the long-term risk of psychosis. But in the longer term, if we could, by intervening at this stage, prevent or reduce the risk of developing psychosis in the next 2 years, that would be fantastic. And because this is a non-psychotic, this is a high-risk group but not a group with a disorder, then whatever intervention you provide has to be minimally toxic. So there's a consensus that if we do treat this group, it has to be with something that is very well tolerated and has minimal side effects. So cannabidiol is quite interesting from that point of view. There's been about 16 clinical trials of pharmacological and psychological intervention in this group, mainly small studies, mainly fairly brief. And my colleague, Kathy Davis, has recently done meta-analyses on both interventions for the presenting symptoms and interventions for preventing psychosis. And in both cases, there was no significant effect over and above the effect of just the non-specific effect of attending a clinical service and getting non-specific support. So at the moment, we don't have good evidence. There's an unmet clinical need for treatment in this group because we don't have a proven intervention. So that motivated us to look at cannabidiol in this group. These patients are from the same catchment area as Martha described in South London, which is shown in red here, where we have a very high incidence of psychosis and obviously lots of people at high risk for psychosis. So the early detection service for this group is called OASIS, and we recruited all the patients for this trial from there. So the design of the study was very simple. Subjects would present to OASIS where they would get non-specific clinical care without a specific intervention, except they would either get cannabidiol or placebo, and they'd be randomly allocated to this for just 3 weeks. So they got 600 milligrams of oral CBD for 3 weeks or a placebo on top of their care as usual, the non-specific support. So this is a small experimental trial. We had about 17 subjects in the cannabidiol group, 16 in the placebo group. You can see the average age. We're not talking about adolescents or children here. This clinical high-risk population is average age is 24, so we're talking, they're quite old in terms of psychosis risk. The two groups were matched for demographics. The main instrument that's used for assessing prodromal or high-risk symptoms is the CARMS, the comprehensive comprehensive assessment for the at-risk mental state. And the total CARMS score that's shown here is just the sum of all the psychopathology at that stage. But it has, a bit like the PANS, it has subscales for the positive psychotic symptoms and negative symptoms, and these are shown here. So these are, we haven't published these data yet. This is an exclusive preview for you of these preliminary findings, but I don't think that the main findings are going to change much with further analyses. So I'm going to show you the main findings today. And the first was that the overall symptom severity, as measured by the total CARMS score in the CBD group, reduced by about 35%, which was almost twice as much as in the placebo group. So this suggests that CBD might be having an effect on the presenting symptomatology. And there was also a significant effect for the distress associated with psychotic symptoms. So these individuals have a lot of this distress when they present, and this was much more reduced in the cannabidiol arm than in the placebo arm. We also looked at other symptoms, and really there weren't really any striking effects there. There was a suggestion, which was just significant, of an effect on negative symptoms, but that the levels of negative symptoms at this stage were not particularly high, so I wouldn't set too much store on that. And these clinical high-risk individuals are exquisitely sensitive to pharmacological side effects. So if you give them an antipsychotic, they are much more likely to experience adverse effects at tiny doses than a patient with psychosis. However, with cannabidiol, as in the other studies, the incidence of adverse events was no different from placebo. We used the UKU scale, which is an antipsychotic side effect scale, to look at this. So again, CBD seems to be very well tolerated. Okay, in addition to this clinical trial in the same individuals, we also wanted to understand a little bit about the mechanism of action of CBD. So I think you'll hear probably in the next presentation a lot more detail about this, but the bottom line is that CBD has multiple pharmacological mechanisms of action. We don't know which one is most relevant to its possible effects on psychosis. So we wanted to try and capitalize on the fact that we were doing a clinical trial to look at that issue in the same patients. So we did this by scanning them before and after the 3 weeks of treatment. So they underwent functional imaging with functional MRI at baseline and then at the end of the 3-week treatment period. And then we used functional MRI to look at the response in the brain to CBD compared to placebo. And we've already published the results of just the first single dose of CBD compared to placebo in this same data set, and that came out last year in JAMA Psychiatry. What I'm presenting today is the effect of the full 3 weeks of treatment, the full course of treatment, not just the single dose. And the task that we used was a verbal memory task, which in previous studies in healthy volunteers was found to be very sensitive to modulation by CBD, particularly in the striatum and in the hippocampus. So what these slides show is this is the horizontal slice through the brain, this is the hippocampus, this is the striatum, and in these two regions, during the verbal encoding part of the task, the effect of CBD compared to placebo over the course of the treatment was significantly different. So placebo is shown here in black, and in the hippocampus, placebo is tending to reduce activation in the hippocampus, whereas CBD is doing the opposite. In the striatum, it's the other way around. Placebo is increasing activation, CBD is reducing it. So significantly different modulation of function in these two crucial areas for psychosis by CBD compared to placebo. And we also we saw a similar kind of thing in the other part of the task is when subjects have to recall words that they've learned. It's a verbal recall condition. And again, in the striatum, opposite effects of CBD and THC in these patients. So These effects give us a clue as to where in the brain, in patients, CBD may be having an effect that might be related to its effect on psychotic symptoms. And the location of these regions is particularly interesting because of what we know from a whole raft of independent research on the areas involved in the onset of psychosis. So, roughly speaking, the most popular model is that hippocampal dysfunction drives striatal dysfunction and dopamine dysfunction. And these two regions, the hippocampus and the striatum, were where we've found CBD in these high-risk subjects to be having its maximal effect. So in this high-risk population, CBD seemed to reduce the presenting symptoms, and it seemed to also reduce the associated distress, and it was associated with no more adverse effects than placebo. And in addition to that, these clinical effects were associated with significant neural effects on the response of the striatum and the hippocampus. Okay, so in the last bit of the presentation, I'm just going to mention a few next steps. So we've got these promising results from early phase clinical trials in schizophrenia and in high-risk subjects, but these have been relatively small phase 2 trials. And really the next stage is to do, we want to confirm these results in much larger scale studies, multi-center trials with much larger samples. And the second issue that we want to address is the mechanism of action of CBD. So if CBD does have antipsychotic and anxiolytic properties, it's very important to understand the molecular basis of that effect, because it might reveal a new therapeutic target that would be useful for schizophrenia and psychosis. So we plan next year to start large-scale studies of CBD in patients with psychosis. So we've brought together a number of multi-center consortia from high-risk first episode and treatment-resistant schizophrenia, and made a network of about 25 centers, mainly in Europe and North America, where we're going to recruit patients for 3 large-scale clinical trials of CBD, one in the clinical high-risk population, one in the first episode population, and one in the treatment-resistant population. So these studies are due to start next year. And as we did in the clinical high-risk study that I presented already, we're going to capitalize on these clinical trials to try and understand the mechanism of action of CBD. So in all of these trials, the participants will be assessed serially with biomarkers before and after treatment to try and understand how CBD is acting on the brain. So we can use neurochemical imaging, for example, to try and get at which particular molecular target might be relevant to the therapeutic effect. And as a psychosis researcher, CBD is very exciting for me because it, in my opinion, represents one of the best candidates of a new, potentially new class of treatment. Although we don't know exactly how CBD works in psychosis, we do know that it's very unlikely to be through D2 antagonism. So if it does have therapeutic effects, it will have a distinct mechanism of action to all existing treatments, which are basically all antipsychotics are D2 antagonists. So if CBD can be developed into a new medicine, it would be a bit of a landmark because it would be a new class of treatment for psychosis, which would be fantastic. So thanks very much for your attention. I just want to thank all my colleagues at various places around the world who've contributed to this work, and I'm very happy to take any questions. Thanks very much.
We certainly have time for questions.
Hi, I'm Tony Altar, and working in the hippocampus, we discovered that a muscarinic receptor target would be a reasonable agonist approach to treating schizophrenia, and that was based all on genomic profiling of human hippocampus, and that was about 10 years ago. It was very interesting to see that just a couple weeks ago, Karuna Pharmaceuticals showed that xanomeline, a very selective M1/M4 agonist, treats schizophrenia with a very significant effect. And also the GWAS studies show that the only two GPCRs that are associated in a GWAS manner with schizophrenia are the D2, and interestingly, we've recently shown the M4 receptor. So it's interesting to find that just this year there's been a report that muscarinic agonists can normalize by increasing muscarinic receptor numbers in the brain. So do you think possibly by cannabidiol? So do you think it's possible that the muscarinic receptor agonism may explain the cannabidiol effects that you're seeing?
Yeah, so I mean, I totally agree. I think that the data you mentioned is fantastically interesting. Whether CBD could act through that receptor, I'm not an expert on that. Maybe Sachin could comment. No, okay. So. Okay. So Yasmin, did you hear that? The expert is going to answer.
No, I was just saying that CBD does have a muscarinic tone to it, but the specificity to the M4 it's not at least yet shown. But it does have a muscarinic tone.
So it's consistent with this possibility. Thank you.
Yes, two questions, and I apologize if I'm ignorant about them. Number one, you show us how nicely the CBD prevents these acute psychotic effects of THC. Has that been shown for acute administration of a stimulant drug, like a methamphetamine or amphetamine? That's one. And the second one, I mean, certainly it does appear that THC may be contributing by itself to the risk of the emergence of psychosis. Have we looked to the extent that there is a different response to treatment among patients with schizophrenia who have a history of marijuana versus those that do not? And this is specifically for your trial with CBD that shows benefit in some patients and not in others. So do we know if patients for whom exposure to THC may have had a contributory effect respond differently to CBD?
Okay, yeah, great question. So the first one, I'm not aware of any other studies that have used other stimulants with this CBD pretreatment approach. In terms of your second question, I hate to draw on the audience, but Professor Murray probably knows the answer better than me. So the question was, do people with a history of cannabis use with psychosis respond differently to treatment to those that don't?
Well, we know in general the critical thing is whether they stop taking the cannabis or not. And if they do stop taking the cannabis, then there tends to be a slow improvement. Actually, Celso Arango has shown in the longest follow-up that it may take 2 or 3 years before the people who were cannabis-induced psychosis begin to diverge and have a better outcome than idiopathic schizophrenia.
Okay, thank you.
Can you cast some light as to why you think that the CBD trial, the BOGS trial that was reported last year, gave so much poorer separation from placebo than when they did the amilpride trial with CBD? The doses, if I recall, were the same at 600 mg.
So is that the trial from Yale?
Yes.
Yes. Yeah, it's a really good question. So for people in the audience who don't know, that trial was essentially negative, but you're saying they used the same dose and so on. I think that it's very difficult to know, frankly. I mean, they used a different formulation of CBD, and there is a bit of variability in the formulations. I don't know exactly what the nature of their formulation was, but it wasn't the GW formulation, so I don't know if that's got something to do with it, but it's very difficult to explain.
Hi, over here. Just curious, did you guys measure blood levels of any of the antipsychotic medications they're on? Because one of the things we've learned from the epilepsy trials is that CBD actually pretty potently interacts with hepatic enzymes, and it has a big pharmacokinetic effect. And some of the work that's come out of the Australian group would suggest that some of the effects, at least in epilepsy models, given the unknown molecular target of CBD, might actually be due to an interaction between CBD and the elevated levels of the current therapeutic drugs that they're on. I didn't see any data if you guys had actually measured the antipsychotic or other medication drug levels they're on.
So I think it's a really important point. So particularly for benzodiazepines and clobazam in particular, there is definitely an interaction with the hepatic enzymes. In this study, I don't think we did have the antipsychotic blood levels, so it would have been really interesting to do that, but I don't think we're able to look at that.
Okay, if you do that in the future, it would be really good to know that.
It's a really good point.
I think the other thing to point as we talk about the mechanism of what CBD is Brian Roth has run CBD through his multi-GPCR assay, and he said he's not been able to see it bind to any receptors. So I think the chase is still on to find the mechanism, but it is some of the things that we find in some of these in vitro studies actually are using quite high concentrations of CBD that will never be achieved by in vivo administration in humans, and so understanding those as potential mechanisms is going to be tricky.
I agree. Yeah. Thank you.
Hi, Philip. This is a bit related to Nora's question. So were any of your trial participants cannabis users?
So most of the people in the schizophrenia trial came from Eastern Europe, and the cannabis use in these particular catchment areas was quite low. So we did test for THC, and there was, I think, one patient tested positive. So very few were cannabis users, current cannabis users.
So CBD is used by millions of people, right? And I'm just wondering, in the case of your psychotic patients, you had reduction in medial temporal lobe and striatum activation, but what about ordinary people? And if that also happens in non-psychotic people, what do you think the consequences? Is that a good thing?
Yep. So, I mean, a lot of the CBD that's kind of available over the counter is very different from the pharmaceutical grade CBD used in these trials. So in these studies, it's pure CBD with nothing else in it.
Yeah. So in general.
But also the dose, so the amount of CBD, we're giving, a gram of CBD in the schizophrenia trial, whereas in an over-the-counter preparation, there might be a tiny amount of CBD. So it's difficult to know whether you would see similar things with these different types of preparation.
But if it were the same, would that be a good thing or a bad thing for ordinary people?
Yeah, it's a difficult...
I'm thinking about the fact that I don't know, there's a large number of people here. Maybe there are some people here who are taking it for pain or whatever it is.
Yes. I would just be speculating. I don't know.
Okay.
Really great talk. And this question might answer some of Matt's question as well. For the adjunctive treatments, did you see any changes in the side effect profile from the amisulpride or any of the other antipsychotics? Because that might get at whether the metabolism is being affected.
I mean, that would have been really interesting. We did try and look at whether there were differences in relation to which antipsychotic they were on, but the numbers on each different antipsychotic were really too small for it to be statistically meaningful. So in future studies, we will definitely do that. And probably we would control which antipsychotics they were on so that there was much more power to do that. But in the study that was done, there was such a mix. There was 4 people on one drug and 3 on another that you couldn't really get into that kind of analysis in a meaningful way.
And as far as the classic, the UKU, we've looked at the potential that there's no side effects from cannabidiol, but are there things beyond what we generally expect from a D2 antagonist that might be...
I think that's a great point. So, the scale that we used was not designed for cannabidiol side effects, but for antipsychotics. So coming up with a cannabinoid-specific adverse effects instrument would be really helpful, actually. I'm not sure if there is one, but...
I think Bertha has her hand up.
Okay. Yes.
What is it and who's using it and who has it?
Okay, I couldn't give you the technical details, but I think there's lots of assays out there. I mean...
Because it would be very, very important to start doing pharmacokinetic studies in patients receiving CBD plus or minus other psychotropics, antipsychotics, whatever.
Well, I mean, the case of CBT is very important because if the bioavailability of oral CBD without food is only 5%. With food, it's about 25. So it's a very important issue.
Food varies, and hepatic enzymes vary. We really need to use that assay. Is it a radioimmuno or is it an immunoassay? What is it?
I'm sorry, I don't have the details.
Does anyone? Well, MS is too expensive to do routinely on any set of patients. So there needs to be something like an emit or a radioimmunoassay or something. Thank you.
All right. Thank you very much, Dr. McGuire.